Hi everyone, I am Dr. Sagar Sahu and welcome to Vet Surgery. So today I welcome you to the 6th lecture in the series General Surgery. I am covering the eye. I have covered portion of eye in 4th and 5th lecture. I will give the link to those lectures in the description. Okay, I will give the link to entire playlist in the description. You can check them out. Today we will be dealing with eye only, some portions of the eye, and also in the next class. After that it will be finished. General surgery. Today we will be dealing with the nasolacrimal apparatus, conjunctiva, eyeball and orbit. Okay, so before going to the lecture, some formalities. Many times I actually forget this one to tell you that you should subscribe to this channel, because nearly 46% they do not subscribe, but they are watching my contents. Please do subscribe. I usually forget. I don't pay attention to this. So you follow me in the Instagram. This is most important. Facebook I'm little bit irregular, but in Facebook I post different surgeries which I do in detailed manner what I did. And in Instagram you will get the updates regarding the video as well as the PPTs and notes are shared in Instagram. Okay, so this is the book which I am referring for preparing these lectures on eye. This is a very good book. I will give the link in the description. You can download it and you can read it for further studies. Okay, and regarding, see, I am in earlier series like radiology and anesthesiology, I was giving notes, but nowadays I am getting very less time for preparing the notes. Okay, so I am sorry for that, but I will give the link of this PPT in the description as well as the link of the book. You can do further studies. Okay, so first one is the nasolacrimal duct obstruction, only disease of nasolacrimal duct. So many times you may find nasolacrimal duct obstruction. You can diagnose this obstruction by fluorescent dye test. I have discussed regarding the fluorescent dye test in the 4th lecture. Okay, when I was discussing the eye examination and the terminology regarding eye. So you can refer this particular how to conduct this test. Okay, so to that particular lecture. So what you have to do, suppose there is some nasolacrimal obstruction, then you have to pass a nylon thread, usually caliber of 20 or 30, through the superior puncta. You know there is two puncti, that is superior, here will be the inferior puncta. Most commonly the superior puncta is used for the insertion of the nylon thread. So the nylon thread will be passed, it will come out through the nose. Then you have to pass a catheter acting as this wire, or this nylon thread will act as a guiding wire, and through that a catheter will be inserted. Okay, so and it will come out through the nasal orifice. Then simply you have to suture it, and you have to leave it for 2 to 3 weeks. Although these cases you may not get regularly or frequently, but you should know that this is the procedure to do it. Okay, otherwise suppose you do not have this catheter, simply pass the wire and do some movement. Okay, it will reduce the obstruction, or it may dislodge the obstruction if there is any. Okay, next one is the important one, conjunctivitis. Sometimes it comes as a short note or long question in examinations. Conjunctivitis. So there is, you can take a screenshot of this one. There is different methods of classifying the conjunctivitis. Based on etiology it can be classified, based on duration it can be classified, based on the appearance it can be classified. Based on etiology, you know that it may be bacterial, it may be viral, fungal, parasitic, immune mediated, toxic or chemical mediated, tear film abnormalities. Okay, or due to some friction, may be endogenous or exogenous friction. Friction may be due to foreign body, dust, sand, smoke, all those things. There are different parameters. Okay, you can check them out. Based on duration, it may be acute, subacute, chronic and recurrent. Based on appearance, mucoid, purulent, mucopurulent, hemorrhagic, follicular, membranous, pseudomembranous, and lysanious. All these are the classifications of the conjunctivitis. Parasitic conjunctivitis, you know the species. First, this thalagia, you might be knowing this one, thalagia. Okay, many a times in Instagram reels or different Facebook reels or all those things, videos you might have seen the surgeons taking out a worm from the eye. That is basically thalagia species. Thalagia species. Okay. Apart from that, Onchocerca, Dacia, Ostrosobis, Oxyspirua, Habronema, all those things can act as a parasitic conjunctivitis. For them, you have to do some ivermectin therapy as well as some manual removal. All those things you can do. You should know this from examination point of view. Clinical signs of conjunctivitis, you will find ocular discharge. Obviously, when there will be conjunctivitis, you will find ocular discharge, mostly mucoid. Chemosis, basically it means ocular edema. Ocular edema is known as chemosis. Ocular edema. Conjunctival hyperemia, increased blood circulation, abnormal swelling, emphysema, follicular formation, pruritus, itching, okay, hemorrhage, all those things are signs of conjunctival pathology. Here you have to differentiate between whenever there will be conjunctival pathology, there will be some different blood vessels. There are two types of blood vessels. One is conjunctival vessels, another one is episcleral vessels. How to identify these two? The upper picture is of conjunctival vessels. This one is the episcleral. I'll go bit by bit. Okay. The technical term is conjunctival when there will be hyperemia, conjunctival injection and episcleral injection. Okay. So what is the difference? Conjunctival vessels are finer while the episcleral vessels are larger. You can see here the vessels are much more finer while these vessels are larger. This episcleral vessels, you can see they are larger. Branch frequently, branch occasionally. You can see conjunctival, there is many more branching while these are very less branching. They are very less branching. Okay, or very less branching comparative to the conjunctival. Form arcades or loops at limbus, at the limbar region. They will form different arcades like this and these networks, all those things. But here they will simply move through it. Okay, drive through this sclera. They will go and disappear at here. Okay, they will not form any arcade or loops or networks. Pink or red in color, their episclera are dark red. You can clearly see this one is slightly pinkish, while this is very red, dark red color. Okay, dark red color. Next is mobile and fixed. The conjunctivals are mobile while this is fixed because the conjunctiva can move over the sclera. So this is mobile and this is fixed because the sclera is kind of fixed. Whenever there will be conjunctival vessels affected, then you will find conjunctival hyperemia in bulbar, palpebral area, furnicle. Wherever there will be conjunctival, you will find third eyelid, and all are involved. But here it will only over the sclera, that is this white portion. Okay, not on the palpebral conjunctiva, not on the fornix regions. All those things will not be affected when the scleral vessels or during the episcleral injection. Tortuous root, you can see that the conjunctival are very much tortuous while they are relatively straight, okay. Blanch rapidly when there will be, you will be using topical diluted epinephrine. Blanch simply means when you will apply there will be vasoconstriction, so this pinkish nature will become pale, okay, but not with this one, not with the episcleral, okay. Blanch slowly, very slow, but rapid in case of conjunctival vessels. Individual vessels tend to be indistinct. You cannot identify any individual vessels, but here you can see these individual vessels. These are individual vessels. Okay, these are individual vessels. Vascular discharge often mucoid or mucopurulent. In case of episcleral, this is serous. Pupil size usually normal. Here you may find miosis or mydriasis. Intraocular pressure usually normal. In case of the episcleral, you will find whether high or low. Chemosis is often present, ocular edema. Chemosis is sometimes present in case of episcleral injection. Diffuse corneal edema, diffuse corneal edema often present. Okay, commonly we will discuss regarding the corneal edema in the next class when we will discuss the cornea. Presence indicates conjunctival or superficial corneal disease. If there is episcleral injection, it indicates scleral or deep corneal disease, glaucoma or uveitis. Okay, so these, by identifying these vessels how they look, you can suspect some diseases. Okay. Next, this is just take this screenshot of this one particularly. Okay, I will not explain this much. Okay, so how to do suspect the conjunctival disease? There are different symptoms. Okay, these are different symptoms which you can identify. Based on symptom, you have to follow these procedures. So you have, these are basically the differential diagnosis. This is differential diagnosis. These bold letters are basically the methods by which you have to differentiate. Okay, methods by which you have to differentiate. These are the methods and these are the things which you have to rule out or differentiate diagnosis. You have to do differential diagnosis. Okay, you can take a screenshot and you can read upon it. Next is a very important one. Very commonly you may find in case of dogs. Okay, whenever you will find any ocular disease, you may find this particular case. Okay, many a times you may find this one. So the disease is Keratoconjunctivitis Sicca. So by definition, it is basically the deficiency of aqueous phase of precorneal tear film. Tear film has three distinct layers. First layer is known as lipid layer. Next layer is aqueous layer. The layer which is most adjacent to cornea is basically the mucoid layer or mucous layer. Okay, mucus is secreted by goblet cells, aqueous secreted by the lacrimal gland, lipid by meibomian gland. So it has three distinct layers. So basically Keratoconjunctivitis Sicca means there is deficiency of this aqueous film. Okay, there is many reasons. So etiology can be drug induced. Sometimes when you use specific NSAIDs like Etodolac, then you may find this particular Keratoconjunctivitis Sicca predisposes to Keratoconjunctivitis. Usually it causes dry eye, then it develops, the Keratoconjunctivitis Sicca develops. Sulfa drugs, general anesthetics. So whenever you are in OT and you have used general anesthetics and the eyes remain open, so the surgeon will tell that put 1 to 2 drops of artificial tear regularly so that the corneal drying should not occur. Okay, so general anesthetics can cause the Keratoconjunctivitis Sicca. Surgically induced, suppose you are doing third eyelid gland removal, you have to keep the eye persistently open, then it may cause dry eye and Keratoconjunctivitis Sicca. Immune mediated, it may be idiopathic, patient to patient vary. Trauma to orbit, infection like canine distemper virus, loco-weed poisoning, congenital acinar hypoplasia of lacrimal gland. Other causes like dehydration, debility, vitamin A deficiency, all those things can contribute to Keratoconjunctivitis Sicca. These are the clinical signs of Keratoconjunctivitis Sicca. You will find lusterless cornea, corneal vascularization. Here it is important. Okay, you have to differentiate between the conjunctival vessels as well as the scleral vessels, episcleral vessels. Pigmentation, different blackish pigmentation, ulceration, dry, sticky, mucopurulent discharge. This is very much characteristic, dry, sticky, mucopurulent discharge. And ipsilateral nostril, you will find drying of ipsilateral nostril. Okay, here suppose this eye is left eye is affected, then the left nostril will be dry. Okay, so these are the basic signs. You can see here a picture, mucopurulent sticky discharge. Okay, mucopurulent sticky discharge, and the cornea is lusterless. Okay, you can see that. This is basically the typical clinical signs of Keratoconjunctivitis Sicca. Now what is the management? Management is mostly medicinal rather than surgical. Okay, mostly medicinal. In surgical, you can do membranoplasty, third eyelid flap, okay, not flap, third eyelid covering the cornea. We will discuss in the next class. When we will discuss cornea, there I will discuss the membranoplasty. Okay, so the medicinal measurement comes in 5 steps. First step is basically stimulate natural tear production, like if you will use cyclosporin drops or tacrolimus drops or ointments, then you can promote natural tear production. Second step is replacement of the precorneal tear film. There are various drops and gels and ointments are available consisting polyvinyl alcohol, dextran, methyl cellulose, chondroitin sulfate plus sodium hyaluronate, ointments containing petrolatum, mineral oil or lanolin, all those things can be used. Third step, reduced ocular surface inflammation. Topical cyclosporin can be used, tacrolimus can be used, dexamethasone and prednisolone, these two steroids drops can be used, but it should be used after fluorescent dye test. This fluorescent dye test will confirm that whether there is any corneal ulcer or not. If there is corneal ulcer, then the steroid eye drops are contraindicated. So whenever you are finding some cases of Keratoconjunctivitis Sicca or you are finding some mucopurulent discharge, do not go for any drop containing steroids. First try with simple antibiotics or any other composition, avoiding steroids. Okay, because in field you may not be finding the fluorescent dye test. Okay, the chemicals required for fluorescent dye test. Simply avoid steroids. Okay, unless and until you are very sure that there isn't any corneal ulcer. Control secondary infection, next step. Okay, by systemic or local. Removal of excess mucus. There are sterile eye washes, sterile cistern wash, all those things are coming through which you can wash the eye. And important one is the last one, regular follow-up. You have to check of the patient regularly, or you can advise the owner to bring the patient regularly to your clinic for the further follow-up. Okay, so this is basically Keratoconjunctivitis Sicca. Traumatic proptosis, next disease, traumatic proptosis of globe. Mostly you will find in brachycephalic breeds, commonly brachycephalic breeds, because they have a predisposed to this proptosis, because their eye is partially out of the globe always. So whenever there is infighting or any injury, the globe will come out. Okay, otherwise you may find also in different other species, in desi dogs, Indian dogs, during the fighting you will find this proptosis. So the technique is, what is the technique, what is the surgical technique? This is proptosis, globe coming out of the orbit. So first you have to do a tarsorrhaphic suture. So first, this is the upper eyelid, this is lower eyelid. So you have to take a bite on upper eyelid. Remember, you should never puncture the palpebral conjunctiva. It should come out like this. Okay, like this, not like this, because this palpebral, if you are puncturing this palpebral conjunctiva, this will irritate the cornea. If you will do it tarsorrhaphy, then it will irritate the cornea. Okay, understood? So now you have taken a bite. Okay, this is the loop and this is the upper eyelid, this is lower eyelid. You have taken a bite on lower eyelid like this. Okay, 3 sutures you have put. You may put more sutures depending on the size of the animal. So you have put 3 sutures. Now place a back side of BP blade, Barker handle. Okay, sorry, not blade, I am sorry, handle. So the back side of the handle you can keep here like this, simultaneously pulling the sutures and pushing the eyeball by the back of the handle like this. Okay, then it will have a popping sound, pop, then it will go back, okay, into the glue. Next, simply tie the knots. Here you can see that it is only covering the skin portion of the eyelid. It is not coming like this. Okay, it should not be like this one, otherwise it will irritate the cornea. Understood? So here you have done the suturing. You can see here the suture is only at the skin portion like this. This is not like through and through. Okay, you should not puncture the palpebral conjunctiva. This is the suturing. You have to keep for 1 week, 2 weeks. depending on the severity of the cases, and you have to give the systemic antibiotics and the anti-inflammatory drugs. Okay, so this is traumatic proptosis of the eye. This is very important, glaucoma. So before going to the subject, you should know some basic concept. So here this is aqueous humor. So the aqueous humor has two things, like there will be a production source and there will be the outflow activity or outflow facility. So the production is by the ciliary apparatus. Ciliary apparatus secretes the aqueous humor, and the outflow is through, will be through the trabecular mesh. Okay, now whenever there is whatever is produced, similar amount is going out normal. Suppose there is normal outflow, but the production is less, then pressure will fall. Like suppose there is some uveitis or some drug induced, then there will be fall in pressure. But our concern is when pressure rises, it happens when the production is constant but the outflow is problematic. Okay, the outflow is problematic, then you will find rise in pressure, which is known as glaucoma. So another concept, how it is drains, how the aqueous humor is drained. So this is the trabecular meshwork. We will see some very good images, electron microscopy images, don't worry. So this trabecular mesh is present at the iridocorneal angle. Here you can see this is lens. Okay, so this is iris and this is cornea. So this iris here, so this is the angle, this is iridocorneal angle. In that particular angle you will find this trabecular meshwork, through which the aqueous humor is drained to angular aqueous plexus, this shorter one, and these bigger venous plexuses are scleral venous plexuses. Okay, it may be drained to this, or it may direct drain to the scleral veins, or it may seep through the ciliary process. Okay, in these three ways it is drained, but predominantly it is through the venous plexuses. Okay, so this is the drainage. Suppose anything happens to this one, there will be glaucoma. Production is constant. So glaucoma can be, remember, it can be primary, or it may be secondary. Primary or secondary. Primary is of two types: close angle glaucoma, and open angle glaucoma. Okay, open angle glaucoma. Secondary is basically, in primary, predominantly the drainage system is blocked. Okay, due to some reason, we will discuss, due to some reason this particular drainage system is blocked, not damaged, blocked, then it is primary glaucoma. In secondary, suppose there is hyphema, which is basically bleeding in the anterior chamber. Those RBCs will block this one. Okay, here the blockage, in primary blockage, it is due to some problem with that particular tissue. Over the years there will be replacement of some tissue will be damaged, those things. But here the hyphema, the RBC is the cause. Okay, the some foreign other than that particular trabecular mesh, it is something other. Okay, that can block, or there is some adhesions, then it can block. Okay, all those things are secondary. Okay, let us see some images, then it will be cleared. So primary glaucoma. So this is basically the open angle glaucoma. This is closed angle glaucoma. What happens, you see here. So in case of open angle glaucoma, what happens, there is some blockage. This blockage may not be some foreign body, it may be due to the own tissue structure, with age, with increasing age, this trabecular mesh will get blocked. Okay, there is an electron microscope photo. Okay, don't worry. So then it is open angle. This angle is open, the angle has not been closed or there isn't any problem with angle, but this trabecular mesh with time has been degraded. Okay, so this is the primary open angle glaucoma. What is closed angle? This is iris, this is iris, and this is cornea. Now there is some adhesion due to some problem or uveitis, like the most common as uveitis. There is adhesion between the cornea and iris. Now this particular angle, the iridocorneal angle, is closed. Okay, now this is closed angle glaucoma. Understood? This is due to degradation of the trabecular mesh, and this is due to adhesion of iris to the cornea. These two are primary glaucoma. This one is the open angle primary glaucoma, this is closed angle primary glaucoma. Next is the secondary glaucoma. This is the image, electron image, you can see here. So this is basically the iris, this one is the iris, this one is the cornea. You can clearly see this trabecular meshwork. Okay, this is trabecular meshwork. Now what happens with time? There might be some blockage. Here it is iris and this is cornea. You can see the meshwork, some open pores are there. Now it has been reduced to only here some one hole, another one here, another one here, but rest are the blocked due to some degeneration, some blockage. All those things with time, with increase in age, may happen. Now this is another severe, more severe case. You can see here, this is iris, this is iris, this is cornea, this is the iridocorneal angle, this particular thing, iridocorneal angle. You can see only small two holes remaining. Okay, so this is primary open angle glaucoma. Understood? Secondary glaucoma can happen due to maybe some drugs which you are using causing some problem in drainage of aqueous humor. Okay, most commonly you will find pupillary block, adhesion of the lens and the iris. This is the ultrasonography picture. This is the lens here, this is the iris, and there is the adhesion of the iris to the lens. Now this is the anterior chamber, this is posterior chamber. Now the pressure in the posterior chamber will rise because the posterior chamber aqueous humor cannot be drained because of this adhesion. Now it will cause glaucoma. This is secondary glaucoma. Ciliary body, vitreous lens block. It means the aqueous humor which is drained through the iridocorneal angle, it's instead of draining through the venous plexus, it drains to the aqueous humor. Sorry, the vitreous humor. Here is the vitreous humor. It drains to the vitreous humor, pushing the vitreous humor cranially, okay, or towards the cornea. Then the pressure rises. These are secondary glaucoma. Understood? Most commonly you will find a primary glaucoma. So how to diagnose the glaucoma? I have already discussed this one. This is the tonometry. Already discussed in the first class of eye, that is the 4th lecture in the series regional surgery. I'll give the link. Okay, simply there are two methods by which the IOP or intraocular pressure is measured. First one is the applantation tonometry, another one is the rebound tonometry. I have explained in detail in those lectures. Okay, no need to discuss here. So by these you can measure the intraocular pressure. Normally it is 15 to 25 mm of opacity, but if it is above 20, then suspect for the glaucoma. This is gonioscopy, by which the iridocorneal angle is viewed. Okay, this is the gonioscopic lens. This is the gonioscopic lens here, through which you have to view the iridocorneal angle. So now there is different important structures, but the most important one which you should remember and see, this one is the pupil, this one is the iris, this is the iris, here to here, this is the trabecular mesh, and here the white is one is cornea. Okay, these structures which you should see. Here another image. So this is the pupil, this one is the iris, this particular structure is trabecular meshwork, and here is the cornea. Here is the cornea. Understood? Now let us see some pathology. Gonioscopic pathology here. This is a case of hyphema. There is secondary glaucoma. Hyphema, bleeding into the anterior chamber of eye. You can see this is iris and this is cornea, and here this is the trabecular mesh which has been blocked by RBC. You can see distinct reddish in color. This is blocked by RBC. Okay. Here there is another image. You can see this is pupil. This is pupil. This is the iris. This is cornea. Now the iris and the cornea has been merged. The iridocorneal angle is only a thin line, that is the iridocorneal angle is closed. It is now closed. Through the gonioscope you can see this iridocorneal angle, especially in case of glaucoma. Okay. Now take a screenshot of this one. Okay. So how to proceed in case of glaucoma? Suppose there is a glaucoma, you have to check whether the animal has vision or blind. Suppose you find that animal has some vision, then you have to differentiate whether it is a primary glaucoma or secondary. Suppose you have found it is secondary one, then treat the primary cause like uveitis, lens luxation, hyphema, all those things you have to treat and check the other eye. Suppose you are finding that it is due to primary cause. Okay, primary or closed, the iridocorneal angle is closed. Start the medical therapy. You can use lantanoprost. It usually increases the drainage of the aqueous humor. You can use mannitol unit, the causes reduction in any type of edema, any type of water through the urine, it removes from the body. Mannitol can be used. 2% pilocarpine, they are basically myotic agent. I have discussed regarding mydriatic and myotic agent in the 4th lecture. You can refer to that. Then you have to recheck the eye IOP after application of this IOP in 1 to 2 hours and evaluate the other eye. Suppose you are finding IOP less than 20, IOC has been reduced below 20 mm of mercury, then continue the medication, consider surgery, counsel the person for surgery. Okay. If it is more than 20, it is not dropping below the 20, simply go for surgery. There are different surgical procedures, okay, like cyclosurgery, photocoagulation, gonioimplantation. If you want details, you can refer in the book, but simply remember the name. This surgery is very rare in case of veterinary patients. Okay. So this is basically, if the animal is blind, then determine the primary cause. Relief only, you can only reduce the pain. Vision may not be restored, but you can reduce the pain. You can go for enucleation or evisceration. Okay, cyclorestorative procedure. These are basically the procedure through which we'll discuss when the orbital disease will come. What is enucleation? What is evisceration? All those things we'll discuss. So you can go for this one. Simply remove the eye, affected eye, and evaluate the fellow eye. If the fellow eye has nearly about 20 mm of mercury or showing the symptoms of glaucoma, then prophylactic therapy you can go for dermacarium. This is basically myotic. Okay, you have to give, and every 1 month you have to evaluate the pressure of the intraocular pressure of the eye. Okay, this is basically the management of glaucoma chart wise. You can take a screenshot and refer it. Okay, next is the orbital disease. This is the last one of this lecture. Orbital disease. Much more things you can find in book. Simply you have to remember what are the diseases. Developmental abnormalities like shallow orbit. Okay, in case of brachycephalid breeds, I told you, due to shallow orbit, the eye is already slightly in proptotic stage. Okay, so they are very much prone to proptosis. Micro means small microphthalmia, anophthalmia, absence of ophthalmos, hydrocephalus with orbital malformation, uriblepharon, orbital arteriovenous fistula, hemorrhages. These are basically developmental abnormalities. Trauma, up to this developmental abnormalities. Suppose there is trauma, hemorrhages, penetrating foreign bodies. Okay, orbital disease simply means disease around the orbit. It may involve anything. Okay, around the orbit. Orbital fractures, bacterial fungal infections, parasitics, like Dirophalmitis, Pneumocystis caninum. All these things can cause orbital disease. There might be neoplasia, very common. You may find neoplasia in case of I have seen many cases in case of large animals. Okay, neoplasia of the eye. Primary orbital neoplasm like sarcoma, meningioma, adenocarcinoma, nasal cavity, any tumor extended from the nasal cavity, lymphosarcoma in case of cattle. Okay, very common. You may find. You have to go for evisceration or the extension. Metastatic or invasive neoplasms. Miscellaneous condition like zygomatic mucocele. We will discuss when we will discuss the salivary glands. Okay, zygomatic mucocele. Infections of the roots of the, this is Possinantrum, carnassial tooth infection, but the opening is just below the eye. It may not involve the eye, but it is around the eye. Okay, dehydration, eosinophilic myositis, Horner syndrome, orbital emphysema, all those things can cause to the, can predispose or can cause orbital disease. Okay, so whenever there will be orbital disease, what you have to do? You can go for three procedures, that is enucleation, exenteration and evisceration. Enucleation, exenteration and evisceration. So what are the, in case of enucleation, you have to remove globe, third eyelid, conjunctiva and eyelid. In exenteration, remove entire all the structures, globe, orbital contents and eyelids, everything will be removed. In evisceration, you have to remove the intraocular content, only the intraocular content will be removed. Okay, it involves uvea, lens, retina, vitreous and eyelids, but the sclera will be retained. Okay, sclera will not be removed. You see here picture, this is enucleation, removal of the only the globe. This only globe is removed, that is enucleation. This is exenteration, removal of all the contents in the orbit. Inside the orbit, whatever the content is there, all will be removed. Now enucleation, this is evisceration. I am really sorry, I told you enucleation, evisceration. Okay, this is exenteration, this is enucleation. Here you have to give incision at the limbus region. Okay, and you have to remove all these intraocular content, lens, vitreous humor, aqueous humor, ciliary body, all those things you have to remove. Okay, all those things will be removed and the sclera will be sutured. Okay, understood? So this is basically the retina, all those things except sclera, everything will be removed. So these are the three procedures for orbital disease. Depending on the severity, you have to choose your surgery. Okay, next is the surgery of removal of enucleation, or simply there are two methods for enucleation. One is the lateral subconjunctival and another is transpalpebral. If you are doing exenteration, simply you don't need anything, simply remove all those things. But for enucleation, there are two approaches. And for the evisceration, I think I have mistakenly told. This is evisceration. This is evisceration. I am really sorry, I got confused. This is evisceration. Not enucleation. This is enucleation. Okay, I am really sorry. Sometimes in flow while teaching, I took my mistake. Okay, so this is for enucleation there are two procedures. First one is the lateral subconjunctival. So what you have to do? So first you have to perform a lateral canthotomy. Next, give incision at the limbus region to separate the conjunctiva. Here there will be bulbar conjunctiva, so you have to separate the conjunctiva. Conjunctiva is attached to the eyeball, so you have to separate. After separation, go on blunt dissection, cut those muscles, ocular muscles, and reach up to the posterior side of the eye. So here will be optic nerve. Remember, do not clamp the optic nerve very tightly or pull the optic nerve. Animal may enter in shock stage. Okay, so be careful, handle gently. So when you got the posterior side, clamp slightly, then suture, place a suture, then cut it out. So after the removal, remove the third eyelid, This is third eyelid. Third eyelid. Remove the third eyelid. Next, this is the conjunctiva. Suture this conjunctiva. Remove this eyelid. Upper eyelid and lower eyelid will be removed. Okay, this is the suturing of the conjunctiva. Next, the skin. When the eyelid is removed, only skin is remaining. The skin is sutured. This is lateral subconjunctival. My favorite one is the transpalpebral. Transpalpebral. Before going to the transpalpebral, in case of large animals, there is a technique known as 4-point block. 4-point block. The advantage of this particular block, first of all, it will produce the anesthesia of globe. Second, due to the administration of large volume of local anesthetic, it causes proptosis. It causes proptosis, so that it is very easy to dissect out the eyeball from the orbit. Okay, so this 4-point block, east, west, north, south, you have to give. And remember, this needle, suppose this needle should be made curved like this slightly before insertion. Okay, like this 4-point. Before doing the 4-point, you have to go for auriculopalpebral block as well as the local block around the palpebra to paralysis the palpebra. Then after, you have to go for lift the palpebra and go for 4-point block in case of large animal. In case small animal, mostly general anesthesia is used, but in case of large animal, local anesthesia is used or regional anesthesia is used. For that, you have to go for 4-point block. So what you have to do? First, suture the eyelid. Give incision around the eyelid like this. Give incision around the eyelid. Then go for dissection. By dissection, remove the globe, cut the extraocular muscles, find the stalk. Do not pull it hard, because optic nerve, by pulling the optic nerve hard, you may make the animal go into the shock stage. Okay, so simply be gentle. Then suture it the stalk. Simply suture this palpebra. Okay, skin actually. Thereafter only skin will be there. Simply suture it. So this is, you can give a subcutaneous suture also. Then after the skin. Okay. Otherwise you can go for directly skin. In case of large animals, this is for dog and cat. In case of large animals, you can pack this one with betadine, soaked betadine gauze or the povidone iodine gauze. For suppose you may not find, suppose you have ligated this one, but there will be some diffuse bleeding. To control that diffuse bleeding, you can pack it with gauze, and simply a small opening will be there at the medial canthus, and after that, after 2 to 3 hours, the gauze will be taken out. There will be no further bleeding. Okay, in case of large animal, I am telling. Small animal, it may need it simply by manual pressure with gauze. The diffuse bleeding can be controlled, or also there is some electrocautery, all those things have been there, so they can be used. But in field, still we are doing some manual things. So for field, you can do gauze packaging. This is a practical technique. You may not find in book that you have to do gauze packing inside the orbital cavity during enucleation process. Okay, so this is all about today's class. Next, the last of the ophthalmology. Okay, and the 7th lecture. So till then, tata, bye bye, take care.